Ab-Interno Schlemm's canal surgery, a comprehensive guide to navigate the canal with precision. Touch, tear, and thread techniques. Enter the canal. Treating glaucoma, the leading cause of irreversible blindness, has been a journey spanning decades, but a perfect cure is yet to be found. In developing countries where financial constraints, limited education, and reliance on caregivers pose significant challenges in treating chronic diseases like glaucoma, minimally invasive glaucoma surgery, or MIGS, emerges as a potential blessing. MIGS preserves the conjunctiva and sclera, facilitates earlier patient rehabilitation, minimizes alterations to the eye's anatomy, and can seamlessly be integrated with cataract surgery. While MIGS can be expensive, we sought affordable ab-interno alternatives for the developing world, focusing on options that touch, tear, and thread the canal. Introducing Dr. Ananda, a young and enthusiastic ophthalmologist driven by a passion to make a difference and a profound admiration for the legendary Bruce Lee. She attends a medical conference where she learns about MIGS procedures from esteemed glaucoma experts. During the conference, she witnesses a live surgery where one of the surgeons skillfully tears open the canal. Intrigued by the potential of this innovative approach, Dr. Ananda is inspired to embark on her journey into the world of MIGS.
I said, empty your mind. Be formless, shapeless, like water. Be water, my friend.
She empties her mind and lets her fingers do the practice of intraoperative gonioscopy, the initial step for any MIGS procedure. To achieve this, the microscope should be tilted 30 to 35 degrees toward the surgeon, and the patient's head should be turned 30 to 35 degrees away from the surgeon. Additionally, lifting the head end of the operating table is necessary. Beginning with low magnification, gently place cohesive OVD and the Swan-Jacob gonio lens over the cornea to prevent corneal folds. Once the angle structures come into view, gradually increase the magnification. Proficiency in angle visualization is crucial for performing a variety of angle-based MIGS procedures. Step 1. Touch the angle. Dr. Ananda initiated her practice of intraoperative gonioscopy on routine cataract cases, aiming to touch the trabecular meshwork using a cyclodialysis spatula. Subsequently, she successfully touched the meshwork in several cases.
It is like a finger pointing away to the moon. Don't concentrate on the finger or you will miss all that heavenly glory.
With focus and determination, Dr. Ananda, now looking beyond the touch, prepares to tear open the canal. Step 2. Tear the canal. She explores two options to tear the trabecular meshwork. The first of that is the Cahook Dual Blade, or KDB Glide, which is an advanced goniotomy blade designed to de-roof 90 to 120 degrees of Schlemm's canal through a near-complete removal of the trabecular meshwork, all while minimizing damage to surrounding tissues. The second and low-cost alternative to KDB Glide for the developing countries is bent ab-interno needle goniectomy, or BANG. This technique involves bending the tip of a 25-gauge hypodermic needle towards the bevel and carefully inserting it into the canal. This process involves excising 3 to 4 clock hours of trabecular meshwork, achieving a comparable amount of de-roofing as seen with the KDB Glide. She also notes that a positive indicator of surgical success is the clear observation of a well-defined episcleral venous fluid wave after completing the procedure. Step 3. Thread the canal. After comfortably tearing open a few angles, Dr. Ananda determines to try the most challenging technique of threading the angle with a Prolene suture, that is gonioscopy-assisted transluminal trabeculotomy, or GATT. Performing her inaugural GATT procedure, Dr. Ananda blends determination with a hint of nervousness. The surgical team buzzes with a mix of anticipation and anxiety. Armed with the tips and tricks shared by her mentor, Dr. Ananda embarks on the surgery by making a perfect flange which is atraumatic and not large enough to create a false passage. She makes a small initial goniotomy which is sufficient enough to house the flange tip. She gently advances the suture by employing circumferential strokes, avoiding tangential movements for a precise and controlled procedure. She exercises caution when opening the microforceps, ensuring it's just enough to securely grasp the suture without causing any damage to Descemet's membrane. The highly anticipated moment arrived when the Prolene sutures successfully circumnavigated the Schlemm's canal and emerged from the opposite side. The crucial next step involves achieving a 360-degree trabeculotomy by gently pulling the suture from the side port until the entire suture is removed. She wraps up the procedure by leaving a small amount of OVD in the anterior chamber, effectively acting as a tamponade to control any potential bleeding. Dr. Ananda analyzed the outcomes of her KDB, bang, and suture GAT surgeries. Suture GAT showed the maximum reduction in intraocular pressure, although approximately 70% of the patients experienced hyphema, which resolved within a week. On average, there was a 50% reduction in the number of anti-glaucoma medications after these procedures. The notable advantage observed was the absence of suture-related symptoms like irritation and watering, commonly seen with trabeculectomy, and half duration of postoperative steroid use. Having perfected the techniques of touch, tear, and threading of the canal, Dr. Ananda, embodying the fluidity of water, commenced coaching her trainees. And she recollects the quote, "Knowing is not enough, we must apply. Willing is not enough, we must do."